Femtosecond laser-assisted cataract surgery on a high myope. This is Brian Schaefer. We start our case with a 1-0 diamond blade incision. After that, we instill some lidocaine, 1% non-preserved. You can see that the patient's already had the femtosecond laser perform its initial cuts. This is viscoelastic jelly going in the eye to maintain the chamber. And using the cannula, I stabilize the eye and make a 2.4 millimeter incision. Now the femtosecond laser has already performed the capsulorhexis. It has also performed initial fragmentation of the lens. It's always important to make sure that the rhexis is complete so that you can take it out in one piece without any tags. And at this point, hydrodissection is performed and rotation of the lens is visualized. This is particularly important in femtosecond laser cases as the cortex can be particularly sticky. This is the Centurion coaxial phaco handpiece. I start by sculpting, not quite as deep as I would for a regular non-femtoed case. But you can see excellent chamber stability here. I go in with my second instrument. This is a Connor wand, and I achieve a nice crack, and I complete that crack. We have great mobility of the nucleus here. And now we're working on the hemi piece. We crack the hemi into quadrants, spin it around again, and we go on to create 4 quadrants. Once the 4 quadrants are here, I stick the Connor wand behind that initial piece and flip it into the center. And using the ultrasound setting on my Centurion, I easily emulsify each of these quadrants. Now this patient is a very high myope, a -10, -11. And in high myopes, you have to make sure that the chamber stays very stable because it's quite common to see rapid deepening of the anterior chamber in high myopes. At this point, we switch off of the phaco handpiece and switch it over to irrigation aspiration, and I do this coaxial. Now, as I mentioned with the femtosecond laser, the cortex removal, which is what we're doing here, can be a little bit stickier, can be a little bit more challenging to get the cortex to strip away from the capsule. This cortex really isn't giving us any problem at all. We remove the last little piece subincisionally there. Do a gentle polishing of the capsule, and I do switch to the polish setting. Then I withdraw the handpiece and then re-inflate the capsular bag. Now you can see I have 2 marks on the cornea here at 180 and 0. And if you look closely, right at around 100, there are 2 marks in the cornea. This is actually the toric marks that I've made using the femtosecond laser, because what we're implanting here is a 7.5 diopter DIU 225. This is an Eyhance toric lens that we want to line up to around 105 degrees. Now, I made my marks at about 100 degrees, and then after reviewing the topography a little bit further, I decided that 105 was the right axis for this lens. So I placed the lens right at about 105 and pushing down on the lens just a little bit to maintain its position. I evacuate all of the remaining viscoelastic. You can see throughout this entire case there's been no rapid deepening of the anterior chamber. The chamber's been really stable, and that lens is rock solid stable right at 105. I then hydrate the incisions. And this is really a wonderful patient who stayed perfectly still throughout the entire procedure. The chamber is holding nicely. And at this point, I instill some dexamethasone, moxifloxacin, and ketorolac. This is DMK from Imprimis RX. Pressure's great, and the case is complete.